Hi, my name is Omer Jamy, and I'm a leukemia and bone marrow transplant physician at the University of Alabama at Birmingham. And today I'll be discussing a poster that we will be presenting at the annual meeting of the American Society of Clinical Oncology. It is a trials in progress poster. It's a randomized phase 3 study. It'll be presented Monday morning between 8 a.m. and 11 a.m. That's June the 5th. This phase 3 study is a study for patients with acute myeloid leukemia in second remission or beyond, and it randomizes them to an investigational agent called GPS versus physician's choice of best available therapy. GPS is a vaccine against Wilms tumor 1 or WT1, which is a protein expressed on leukemic cells. And there is early data from phase 2 studies and preclinical data showing that it can be an it can be an agent to keep people in remission if they're unable to proceed to stem cell transplantation. So this phase 3 study actually takes patients in second remission or beyond who are ineligible to proceed to stem cell transplantation, which would be the standard of care for most of these patients if they were transplant eligible. So for ineligible patients, there are not many standard of care treatment options. Actually, the only maintenance drug approved for AML is oral azacitidine or Onureg, which is actually approved in patients in first remission. But for patients in second remission or beyond, there's no approved therapy. So this study would randomize patients in a one-to-one manner to either get GPS or best available therapy, which is physician's choice. The good thing about the control arm is that it lets you choose from several options, including venetoclax, low-dose cytarabine, hypomethylating agent, oral azacitidine, hydroxyurea, or a combination of venetoclax with low-dose cytarabine or hypomethylating agent, or even observation. So it gives you a wide variety of options to choose from. The total accrual is expected to be 120 to 140 patients stratified in a one-to-one manner to receive either GPS or best available therapy, with the primary endpoint of the study being overall survival. The study is open at 50 centers, and the plan is to open it at 20 more centers. It is international. It is nicely accruing patients at the moment. The study is stratifying patients along four axes. That is, so that patients are equally distributed between both arms. The first is CR versus CR with incomplete platelet recovery. The second one is duration of first remission, 12 months or more versus less than 12 months. The third one is cytogenetic risk stratification, which is poor versus other. And lastly, MRD status with MRD positive versus MRD negative.